Hello everyone, I am Dr. Jaya Sharma, Director of Novel IVF in Rajmata Hospital, Aligarh. Today I am presenting you a case of Asherman Syndrome. The patient, aged 35 years old, female, presented with the hypomenorrhea and gradually just spotting at the time of the menses. She had first full-term cesarean 6 years back. Then again, she had a normal delivery 2.5 years back, followed by the normal delivery. She had a retained product of conception. After 25 days of delivery, she undergone a dilatation and curettage for those conception. Since then, she is having a history of reduced flow during periods and pain during periods. Now she presented with a secondary infertility as she was not able to conceive since 2 years. So we did a 2D ultrasound. Endometrial canal is quite thin and irregular. The diagnosis, the ovarian reserve and ovaries are normal, and diagnosis of Asherman was made, and she was advised for hysteroscopy and laparoscopy. Now we planned the hysteroscopy and laparoscopy for this Asherman syndrome. Then for a little about Asherman, what is it? It is the adhesions of fibrosis between the two layers of the endometrium where the lining is made, and every month the menses occurs and the implantation of embryo occurs. So what happened after DNC or after infection, after some excessive curettage, any damage which causes the endometrial lining, like removal of fibroid, removal of adenomyoma, removal of any other tumor from the intrauterine wall, there may be fibrosis or obliteration of the endometrial cavity or cervical canal secondary to infection. Now in uterine cavity adhesions, there may be central adhesions without obliteration of cavity. Partial obliteration and constriction of the cavity means the volume is very less, and complete obliteration of whole uterine cavity. Uterine cavity combined with cervical canal may be one of the presentation of the patient with the hypomenorrhea or amenorrhea. So these are the probability. Now we are presenting a small video how we proceeded in the Asherman syndrome. This is how we move through the cervix to the uterine cavity. There are the multiple fibrosis. A nick is made on the endometrial internal os level. Just we can see a small hole at that the internal os level. Sometimes it is all stenosed and they are difficult to find the normal passes. Then we have real difficulty at that time. In this patient, I can analyze one part of the endometrial canal. The other part means right side, it is much obliterated. So we resected very gradual, very gentle, and making the scope in the view again and again, keeping it inside out, up and down, not to enter in wrong planes. Gradually moving. This is the opening of cavity, gradual. Just keep in the center. Just try to achieve one of the ostia as if possible, and try to dissect in the center. Focus the area of dissection again and again, and dissect always under vision. This is how we are just trying to open the cavity. There was lateral, both the sides there are dense adhesions, and just we are trying to open it gradually, and hopefully we can see this is a fibrotic lesion. I'm going inside and outside again and again just to visualize and not to enter in a wrong plane. There's a fibrotic bends. This is the level of previous scar that we are dissecting off. Now you can see from the right side, on the scar side, I dissected a band, and now we are entering the cavity with flimsy adhesions. The lateral walls are quite convergent. We can visualize the bilateral osteas and not very clear, but this is the ostial region that we can make out. This is the lateral wall dissection we are doing for the fibrotic band. Both lateral walls are constricted. There is a bend in the middle of the cavity. There is a fibrotic tissue, and there are slight flimsy adhesions on the fundal area or in the ostial region. This is how the cavity is opened up gradually. Then the things are to maintain the size of the cavity so that we are having the resection of the lateral wall. As I can see, the fundal is not much of indented and just flimsy adhesions on the fundal side. So I just have a small nicks on the fundus to make the cavity visualize properly and make these flimsy adhesions go away. We can visualize the ostia both the sides and just releasing the bands and having some old blood, collected blood is releasing through these bands. This way, now you can appreciate the cavity formation, you can appreciate the dissection, you can appreciate the ostia. We can see well visualized. Once we dissected the lateral wall, we try to dissect the lateral wall from the internal lobes right way to the ostial level and try to visualize both ostia in the same site from the internal lobe. This is our criteria of dissection. Not much dissection on the fundus size because fundus size is not having much adhesions. The adhesions are mainly on the lateral wall or in the previous scar. So a main target is to lateralize or to resect laterally and in the middle of the center and removing the fibrotic tissue as much as possible and making the endometrial canal in a normal size and shape as much as this is the previous scar or the fibrotic bands, and we are trying to resect the extra tissue that is made on the in the form of bands so that it should not hamper our endometrial lining in the preparation or having the good results. This is the old tissue like old blood collected in between the adhesions. Now you can quite internal loss going gradually. We can appreciate both the ostia from the lower side. We are just having gentle strokes on the fundus, just having the lateral wall strokes so that we can judge again whether we are in the right plane or not. This is how we are making the things easy, we are making the things clear, we are trying to make the cavity in a single sitting as there's not much of the obliteration of the upper cavity in this case. So I am trying to dissect off all the redundant tissue or the extra bands on the previous mark. These are the lower side band, upper side band. We are trying to resect it. Now you can see the beautiful pink endometrium. This is internal loss, quite clear. This is extra tissues that we resected. We can just appreciate the normal cavity, the normal size, the ostia, the anterior wall, the posterior wall, and two lateral walls. There is an extra band that we can resect off so that this should not look like polyp when I do my transvaginal ultrasound and further scan. So I am resecting it off as a redundant tissue and hope this patient should respond with the ethyl estradiol valrate. On the laparoscopy finding, there is not much of the pathology. The bilateral tubes were patent, so that we have just washed the pelvis, and the main part of the treatment was just resecting and making the cavity normal. So it's a very interesting case, very rewarding, and many of the cases conceives spontaneously without any assistance. Now we will prepare this endometrium for 1 to 2 cycles. Then I hope I will let them try for spontaneous conception. If not, then we will add some assisted reproduction to this patient. Thank you.